Um, Welcome everyone to the August meeting, and I'm delighted to present our main guest speaker is Professor Peter Rea, who is saying that the opinion of our support group is one of the finest experts in balance disorders. So over to you, Professor, if you can introduce yourself and then start the presentation, please. Thank you.
Thank you very much, Kevin, for that kind introduction. Hopefully everyone can hear me. Give me a good wave if you can't. And I agree with what you said before we started the recording, that the interaction that my new patients with balance problems have with you, who have had balance problems for longer, is really very constructive and incredibly powerful and helpful for them. So thank you to all of you who help our newer patients with their balance disorders. Now, I've given you some talks over the years, some of them technical, some of them less technical. And today, because it's been really hot for the last few weeks, I decided that you wouldn't want to sit and listen to me for hours on end on a very technical subject. So what I've decided to do is talk to you in a different way, because I think it's important you understand how medical professionals like me or Claire think, and how our understanding has evolved over time, because we don't know everything. It's really important to be aware of that. And I'll say to you when you see me in clinic that what I'm doing with the story I'm getting from you, the examination or the investigations, is building a jigsaw. And each piece of the information you can give me is one more piece of the diagnostic jigsaw for your balance disorder. And it would be most uncommon to have every piece of the jigsaw. So I thought it'd be really interesting to think about two of the best known names in balance who many of you will have heard of, and most definitely any of you who have seen an audiologist or ENT surgeon will have had the tests, and just pick out one key test with a name attached to it, and then have a look back and see what has gone on over the last 150, 200 years to produce that simple test that you have. And when you're listening to all of this, just reflect on some of the extraordinary things these individuals have done during their careers to get the knowledge we've got. Reflect on how little we knew before and perhaps how little we know now. And then try and put that into the context of your current disorder, and where there's frustration that medical professionals can't get a diagnosis. I hope this is of some comfort to understand the difficulty sometimes of getting a diagnosis, because we don't know everything. And I think the other thing to reflect on is you'll see a phrase later in the talk about we all are dwarfs sitting on the shoulders of giants. And that's how we feel as scientists. And hopefully each of us as a specialist can produce a small amount of work that makes a small step forward in our understanding. But we only make that step because of the brilliant work that's been done from people before us. And that's how medicine advances. So here we are. I'm going to present you the life story of two great names. And any of you who have got BPPV, benign positional paroxysmal vertigo, that's the little crystals in your inner ear, will have had a Hallpike's test or a Dix-Hallpike test. And those of you who don't, should have done, because it is a cardinal part of every balance assessment, where you're laying down on the bed, have your head tilted to one side and tilted to the other. And the Dix-Hallpike test is named after Margaret Dix and Charles Hallpike. So here we go. Charles Skinner Hallpike, great name, isn't it? Born in 1900 in India. And he came back to the UK as a young man. And he developed quite a severe medical disease called Perthes disease, which affects the hip, and the hip falls apart as a child. And you'll find many really fine doctors and physicians had medical problems themselves or in their family when they were young. And that's often the driver of young people to go into medicine, to be a doctor. Now, he was a great all-rounder. He's a classical scholar at St Paul's School in London, which is a great private school in London. And he got a scholarship to go to Guy's Hospitals, one of our great central London hospitals between the war. And he got his FRCS, Fellow of the Royal College of Surgeons, in 1931. I can't quite remember when I got mine, but it would have been in the 1990s. So it's part of a journey over decades. Now, what we do as young doctors is we get into medical school, we then start our junior training, we start to try and do some research, and then we get into more senior training. And at that time, we try and go on fellowship training to go to the great centers around the world. So I was really lucky to work at Harvard, the Mass Eye and Ear in Boston, in Cincinnati, at the Children's Hospital and the Cochlear Implant Center in Sydney, and other attachments in Nepal and India. And we go around the world trying to build this great understanding. And Charles Hallpike was a fellow in London and traveled around the world to try and get this information. And you can see he traveled through America, Canada, Europe. And that's what we do to try and bring in expertise from around the world. And as a young doctor, he was starting with electrophysiology, so how the nerves between the brain and the eye and the ear and the rest of the body worked. And I've reflected on this because my initial introduction to balance was in the Downing site in Cambridge when I was an undergraduate in Cambridge. And I spent a year studying the electrophysiology of the nerves that run from the brain down to the hand. And when I put this together for you, it was quite emotional, actually, because in this great centre in Cambridge, the Downing site, there are fabulous names that, for people like me, and maybe you've heard of people like Huxley. Do you remember Brave New World? These great scientist families worked here, and they great oak panelled rooms. And when I'd walk down them, I would feel their ghosts I was walking through. It's a very interesting thing, this sort of continuity of research. But he was doing his research back in 1934. I was doing mine there in 1988, 87. Now, I'm going to bring in a number of balance disorders during this talk that will actually cover most of what you have. And one of the early diseases he studied was Meniere's disease. And that's the disease that causes episodic vertigo, hearing loss, tinnitus, and fullness in the ear. It's incredibly distressing when it happens. And not only are the attacks awful, but also one lives with the fear of when the next attack is going to be. So it's difficult to manage one's life. And his initial work was looking at the inner ear anatomy. What does the inner ear look like? And of course, in a living patient, at that time, you couldn't see because your patient would have to die to take the inner ear out. So it's very difficult to get that anatomy. And what they found was when they looked at the inner ear, the tissue lining the inner ear in the middle of the inner ear was swollen. We call that hydrops. So he was one of the first people to observe idiopathic hydrops, so that something in the inner ear was causing Meniere's disease. And he presented this at the RSM, which is the Royal Society of Medicine, in 1938. And you'll see why that's very significant to me as an ear surgeon as well. And here's a representation. If you have Meniere's disease, in your inner ear, you have two fluid chambers, the perilymph around the outside and the endolymph in the middle. That's the scala media. And then if you have Meniere's disease, these fluid chambers expand and that distorts the inner ear membranes, which causes hearing loss and tinnitus. And then the fluid whizzes through. And incidentally, if you have BPPV, it's in the scala media here that your little was the equivalent of that, not actually here, but it's in this fluid chamber that your crystals break off. And in that equivalent area in the inner ear balance organ, that's where weakness occurs in vestibular neuronitis, causing vestibulopathy. So this is the area we're interested in as ear surgeons. So Charles Hallpike made this observation. He thought, right, the inner ear is where Meniere's is arising. So he thought, if I cut the nerve from the inner ear to the brain, I will stop these terrible attacks of vertigo. So he got a 63-year-old labourer who'd not only had these horrible attacks of vertigo, but had two drop attacks. Now, drop attacks are terrifying. You're walking along and bang, fall straight to the floor. It's absolutely terrifying. You can imagine how dangerous it is if that occurs when you're driving. And he opened up the skull, the posterior fossa, that's at the back of the head here, and took a segment of bone out to cut the nerve. So he cut the balanced nerve. Now, he will have cured the Meniere's disease. But shortly after surgery, the patient became unwell, and there was a great tension in the wound, and the brain swelled, and he sucked out the blood that he had produced from the surgery, and the patient died. The patient died because of their treatment for Meniere's disease. And 1934 is within the lifetime of some of the patients I treat. So this is not some remote history. And to think that now I can give you injections into the inner ear, which will reduce your vertigo by 90%. And we published that in The Lancet in 2016, a really great paper as well. Isn't it? It's quite humbling, isn't it, to think that in the lifetime of some of our patients, people were having these speculative treatments and dying. And have a look at the next example, a 28-year-old engineer. Imagine your son with a 4-year history of episodic vertigo, low frequency hearing loss and tinnitus, classical Meniere's disease. A look at the description in the notes, healthy but nervous. Well, yeah, not surprising, because he had the same surgery a year later and he seemed okay initially. And then 3 days later, he became unconscious and died as well from the surgery. Isn't it terrifying that they then took out the inner ear of this patient, this 28-year-old who died, and found the fluid in there, the eye drops, to confirm the diagnosis. So what we're understanding now with Meniere's disease is all a result of this pioneering but terrifying work that was done less than 100 years ago. Now, Charles Hallpike was then, despite these catastrophes, appointed to be oral, which ear surgeon, at the National Hospital for Nervous Diseases. And if any of you have got neurological disorders, this hospital is still, it's in Bloomsbury, it's not that far from St Pancras Station. It's now the Royal National Throat, Nose and Ear Hospital. And this is Queen Square, just in front of it. And I walk past this when I go to the Royal Society of Medicine every time. I get the train down to St Pancras, I walk past the Royal National Throat, Nose and Ear Hospital, and then I walk over to the Royal Society of Medicine another half hour away. So he was appointed here and he stayed until he retired in the 1960s. Now, after that slightly heavy introduction, we're going to take a flip back to the future, as it were, just to have a think about the caloric test. Because again, most of you will have had the caloric test, and that's the test where you put warm and cool air or warm or cool water into your ears. Now, we're going to go even further back now. We're going to go back to 1906, and this is Robert Bharani. And Bharani is a great name in balanced medicine. He was an interesting character, I'm told. And when his nurse was irrigating a patient's ears to remove the wax, he noticed the patient's eyes were flicking the opposite way. And he said, "Silly person," to the nurse. This is what history tells us. "Make the water warmer." So the terrified nurse went off, heated the water up, but made it too hot. And it was now above body temperature. And Bharani's genius was he noticed the eyes were flicking the opposite way. So with the warm water, the eyes flicked to the same side. So he started thinking, why might this have occurred? And he realized at this point, just 1906, that it was because he was warming and cooling the balance organ in the inner ear. Now, he then got taken prisoner of war by the Russians in the First World War, but he got awarded the Nobel Prize for Physiology or Medicine. And in 1914, the Russians let him out of prison to get his Nobel Prize. And I thought it was quite an interesting reflection on where we are in the world now, over 100 years later. So it was only just over 100 years ago that it became apparent that these inner ear canals were associated with dizziness. Now, 3 or 4 decades later, we come back to Charles Hallpike again, and he developed the classical caloric test that many of you will have had when Michaela in our practice put warm and cool air into your ears. And we looked for 2 things. Is the damage to the inner ear on one side such that it doesn't respond? In other words, you don't feel dizzy. Or is this thing called DP, directional preponderance, which is a bit of an odd calculation, but it says there's something maybe not quite right with the nerves in the brain. So a century later, nearly, the caloric test has stood the great test of time, because most medical innovations go by the wayside, but this has continued. And we find it really helpful because it stays abnormal after the injury. Many of the tests we do become normal as you adapt, but this one doesn't. And I find it particularly useful, A, for looking for evidence of damage to the ear as a cause of your dizziness, and B, if I'm going to treat the better ear, the other ear rather, I need to know that your better ear is actually working. So that's how long ago we developed that. And this is a bit of an odd one, this bit of a technical test. And when you have a hearing test, you go from low frequency up to high frequency. And with balance tests, we can do the caloric, which is very, very slow rotation through to head shakes and thrusting your head side to side at high frequency. So we can almost do that sort of a hearing test of balance. So this chap, do you want to, I don't know who's got their microphone on. Could you just turn your microphones off? Because there's a bit of feedback on there.
Yeah, I think I've done it, Peter.
Oh, you've done it. Okay, well done. Thanks. So he did lots of other things. He looked at barotrauma, explosions on the ear during the war. He set up hearing aid programs. He was a consultant. He helped in the development of rotating chairs and headlights and microscopes. And he published hundreds of scientific papers. In that era, there was just an explosion of knowledge. He got awarded a huge number of prizes. And when I was president of British Society of Otology and Royal Society of Medicine, we still award these prizes to colleagues. And then, again, something I reflected on very much. Just before I was born, he became president of the section of otology of the Royal Society of Medicine. And his name is up on this great oak panel at the Royal Society of Medicine in London. And it was probably the greatest honour of my career when my colleagues elected me to that presidency a few years ago. And so my name's up there as well. So do you see that what I'm trying to get over is this continuity of scientific development over millennia? Now, Charles Hallpike died in 1979, and his eulogy, I think, is a really useful way for people like me to reflect on the evolution of scientific knowledge and for you to understand how we develop knowledge. And his eulogy stated, "I like to think of Charles as supported by his Christian faith. And I'm reminded of what Isaac Newton said of the scientific predecessors. We stand on the shoulders of giants. And I'm sure that future generations of scientists will say that Charles Hallpike was one such giant." So as patients, as doctors and clinicians and audiologists, we have a lot to thank this great scientific entrepreneur for. And you can see how our understanding now has evolved over really what we would now consider absolutely devastating, terrible experiences of a young, fit, healthy 28-year-old dying during a surgery, which we don't need now. So we have a great debt of gratitude to pay not only the surgeons, but those individuals who submitted themselves to treatment. And I wanted to just balance this with a very brief introduction to the other part, the other half of the Dix-Hallpike test, because I think this is a very moving story as well. Margaret Ruth Dix, remember that test I talked about where we drop your head over the end of the bed? We call it the Dix-Hallpike test. And she was born to a clergyman father. And I thought this statement was really nice. Why did she do medicine? And at that time, because a woman could not be a clergyman, I could just see her sitting up like this, just stating it as a matter of fact. The world has changed, hasn't it? Thankfully. And she studied medicine at the Royal Free School of Medicine, which is where my first consultant job was. Now, she was described as an outstandingly beautiful woman with sparkling blue eyes, but she got disfigured in a bomb explosion in the Second World War in 1940. She ruptured her eardrum and couldn't hear, and there were glass fragments in her eyes, ending her surgical career. And for many people, that would be it. But not for Margaret Dix. She threw her life into studying hearing and dizziness and went to work with Charles Hallpike down in London at the National Hospital for Neurology and Neurosurgery that I showed you. And together they were a formidable scientific pair. So at Queen Square, she began to study this new branch of medicine, the branch of medicine that you and I all live, neurootology, balance disorders related to the ear and the brain. And she was a consultant at the National Hospital for a long period of time. And like many great surgeons and physicians of her era, was fabulous at other things. She was a painter and a poet. And she had a very large number of publications. And again, you see she's awarded these prizes that we still award to our colleagues to this day. Now, just like I did with Charles Hallpike, I want to take you back to the future again. So I want to take you back a bit further. Sorry if it's a bit heavy, but I want you to understand where we've come from and just give you some other stories. So I want to go back to 1825 now. How about this? Jean-Pierre Flourens, down in Béziers in the south of France. He took some pigeons and he drilled out the pigeon's ear on one side. Odd thing to do, eh? And what did those pigeons do? They walked round in a circle to the side of the ear that was drilled out. So he began to think, well, clearly the inner ear is doing something important for balance. And in clinic, I'll get you standing up and close your eyes. That's Romberg's test. Then I'll get you marching on the spot, Unterberger's test. And if you've got a balance condition in one's ear, you'll rotate to the side of the balance disorder. And this was discovered in 1825 by Jean-Pierre Flourens. Here's a great picture in 1961 of Prosper Ménière. I'm not going to say the French of his seminal publication, but translating it, it essentially says, a lesson about problems of the inner ear that cause vertigo. So Prosper Ménière in 1861 was the first person to realize that the inner ear can cause episodic vertigo, which we now call Ménière's disease or endolymphatic hydrops. So you get an idea of the timeline here. Then here's a name you'll know, Mach 1, Mach 2, the speed of sound, yeah? So these were unbelievable polymaths. They were experts in so many things, the scientists and physicians of that era. And he developed this very impressive wooden contraption where he could spin his poor subjects upside down and inside out and see what their eyes did and realize that the semicircular canals, those channels in your inner ear, are an important part of balance. And then we skip forward now to 1952 and we come back to Margaret Dix and Charles Hallpike, who brought all of this information together and defined some of the cardinal parts of balance disorders, which we still use nearly 100 years later. So I've talked about Ménière's disease, I've talked about BPPV, and then the third group of disorders, which will embrace many of the conditions that you have, is acute vestibular neuronitis. So a virus of the inner ear causing swelling of the inner ear, causing acute vertigo, vomiting, dizziness lasting a few hours or days, and then persistent imbalance. And those of you who have triple PD, persistent postural perceptual dizziness, this is one of the commonest triggers for it as well. And it was at that time they were able to say that actually these acute attacks of vertigo were on the nerve of balance and not necessarily in the inner ear. And they used their caloric test to demonstrate that. Isn't it interesting? So you see how these two individuals working in London have had such a profound influence in our understanding of balance disorders over the decades. And in that same paper, they talked about positional dizziness. So we go back to Barani, who diagnosed or defined the inner ear as part of the balance disorder when he was syringing and got the Nobel Prize. And they distinguished the various features of BPPV. They found it was positional, dizziness if you look up and down, go to the dentist, put a cup on the top shelf, lie down in bed and roll over. Paroxysmal was intermittent. They used the word benign. It wasn't dangerous. And they developed the Dix-Hallpike test. So here you are. This has brought all of the centuries of investigation together to Margaret Dix and Charles Hallpike's test. And if we drop your head over the bed, we can see different types of eye movement, dependent on where the crystals are. And their description I thought was very interesting at that time. Whoops. Sorry, I've lost the description. There we are. The patient cries out. Well, those of you who have had a positive Hallpike test know what I'm talking about, don't you? It's really distressing. And you get this twisty eye movement, which they defined. But in fact, there's 3 canals on each side. That's 6 canals in all. And you can have 3 states in each canal. You can have normal canal lithiasis with crystals in the canal, or gupular lithiasis, crystals stuck to the canal. And is anyone really good at maths? So how many different types of nystagmus, eye movement abnormality, can you have with BPPV? Well, it's 3 to the power 6. And that comes in at about 720 different types of eye movement just on the Hallpike test. Now, they didn't know that now. And I'm not saying that I know 720 different types of eye movement, but you can see how difficult it can be sometimes. But the key is that they were looking at this area in the ear. But even at that stage, they weren't sure whether this was caused by a problem of the inner ear or of the nerve. So there was a lot still to learn. So they designed this fascinating contraption with pulleys and bits and bobs to spin their patients round. Now, we think we're terribly modern with our DRV chairs spinning people round, but we're not really, are we? We're all developing on the shoulders of giants. Everything we do really has been done before in some iteration. So in this paper, they also put their observations of the otolith organ. Now, again, we're in the balance organ now. Do you remember those semicircular canals, those 3 coils inside the inner ear, which is where most of you have a problem? And you're meant to have this lovely, healthy lining here with little hair cells on it. But when you've got BPPV, this gets damaged. If we do a close-up, here's the lining of your, oops, sorry, I'm having a little spinny turn here, aren't I? There we are. If you look at the utricle, which is the sac where the crystals are meant to be in here, in a healthy one, you have nice cells along the lining and little fragments of hairs which balance the crystals. And then when it's damaged, which is how some of yours will be, that's all stripped away. So on here, those crystals can break off and cause the spinning. And when I do the Epley maneuver on you, or you do Brandt-Darf exercises, we put those crystals back into the utricle. But sometimes it's really difficult to do that. And that's possibly because a bit of this lining actually breaks off as it's done here. And that whole chunk of lining of the inner ear gets wedged in your semicircular canals. And that's why I have to shake your head really viciously-ish to try and get them. Don't do that at home, but shake your head viciously to try and get the crystals out and the skin or the epithelial lining out to get it back into the macula. But this was known all those decades ago. So they defined BPPV on the back of work done by Pirani in 1921, with work from Ernst Mach before that, and 150 years before that from Floren's work on the inner ear. So do you see how there is this progression of knowledge over decades and centuries? And I managed to find their original drawing of the Dix-Hallpike test for you in the archives of the National Hospital for Neurology and Neurosurgery. So there you are, the first time this test was ever drawn. I thought that was really lovely to see that. And they did lots of other really important papers. They worked with Terence Cawthorne, a very famous neurosurgeon, doing further work, and they developed tests for hearing and lots of other famous things. And now we've developed this to use the TRV chair. See how similar it is to those wooden contraptions of 100 years ago. And we now have infrared cameras on you. So having thrown you round, that's Liz, our long-standing clinic manager, by the way, long-standing suffering clinic manager. And then we can record your eye movements. So when you're, when I drop your head over the end of the bed, this is what I'm looking for. Or if it's difficult, we can put it on the TRV chair. And by the shape and pattern of your eye movements, I can tell where the crystals are and what treatment I need to give you. And again, we are all but dwarfs on the shoulders of those giants before us. And we can try and take our understanding and knowledge of balance forward just one little step. And each generation will do the same so that we know more. And if only we could all be alive in 70 years' time, another 70 years' time, to see where this is all eventually led to. It'd be lovely to know where it is, but we are working hard. We are trying to make things better. And although that was quite a sort of, I don't know if that was a challenging talk or not, I wanted you to just get a feel for how clinicians like me have developed our understanding, the limits of our understanding, and what we're trying to do to take things forward and make things better. So that's the end of today's talk. We're going to have a little interlude now with Kevin, and we'll then come back. And I think you've got some questions for me, so we'll turn to all of those afterwards. Okay.
Peter, just before we let you rest, just want to pick up on a couple of things with you. We've just seen that history of the development of understanding and the beginnings of treatment of balance disorder. It was fascinating. In your opinion, are we accelerating? Are we getting faster at our learning, or is it a linear speed at which we're gaining an understanding of balance conditions, or is it slowing down? Where do you think we are now?
Well, I'm sure every generation believes this, but I think we're accelerating really quickly. I mean, we're doing it on many, many fronts. Now, Meniere's causation of Meniere's is a difficult one. We are struggling with that. We've done further papers. We've set up a Meniere's registry, and thank you to all of you who've joined that. But we think part of the problem with Meniere's is it's probably several different disorders presenting with the same symptoms. But with conditions like vestibular migraine, triple PD, vestibulopathy, treatments for vestibulopathy, the developments are coming much, much, much closer together. And we have some really exciting ideas as well that we want to get funding to try and develop for treatment. So lots of the things we're doing are trying to make diagnosis and treatment at home easier, and diagnosis and treatment in general practice easier, because it's so difficult to access secondary, tertiary care. And we have lots of ideas. And some of you will have met my son in the clinic at the London Road Clinic, where he's just doing a bit of management training after university. But he's got some ideas as well of medical technology that we can take forward. And there's lots of us a few of us who are really interested in doing that. So no, we're literally buzzing with ideas.
Good. And AI, will it play a part in our treatment?
Yeah, so absolutely. So one of the companies we set up was about 10 or 12 years ago. So we set a company up called Balance Aid, which is Balance AI Diagnostics. And IBM had a third of this company. We had a third. The university and the hospital had some. And we had the founder of the semantic web, so basically what runs Google, was our consultant on the company. And so we were way ahead of what you'd consider things like ChatGPT. And we were trying to use large language models to develop balanced diagnostics. And we really were on the very edge of this. And we had first round seed funding for it. And we developed that. And then we put in a grant for further funding, which was a big grant. It was £1.5 million grant. And we were turned down because we were told we needed a minimum of 15 million. We were really disappointed at this point. But then if you look at what the big companies like Google, Anthropic, and so on are doing, they're not putting tens of millions in, they're putting hundreds of millions and billions in to develop this. So the answer to your question is absolutely AI is going to make a massive difference. Yeah.
Good. But for now, we'll come on to this later, access to treatment still remains a problem. But thanks ever so much, Professor Rea. We will let you rest for about 5 to 10 minutes, and then it's on to questions and answers with you. So now I've just got a couple of announcements to make, sort of latest news for you to be aware of. First one is Maria Collins there? If she can give us a wave, Maria. And apologies, there's so many. There she is. I can see you waving. Thanks, Maria. Maria is now brilliantly, she's volunteered to lead the support group's work and efforts to track down all the NHS departments that treat balance disorders in the UK. Two reasons we're doing that. One is we want everyone to know about our support group. A big driver for that, you may or may not be surprised, almost every month we have a new contact from someone who wants to join the group who says something along the lines of, I wish I'd known you existed 4, 5, 6, 7. I've even had someone say 20 years ago. So what we're trying to do is get everyone out there who treats people like us just to know the group's here. So for those patients they're treating where they could get some sort of benefit from the group, they'll know about us sooner rather than later. What Maria is doing is pursuing the leads you can give her. So where you've been treated, and you'll get an email about this, and many of the members have already been contacted about this over the last few months. We're just asking you to send in details of where you have been treated, especially if you can get us an email address, phone number's good, and any names. And then Maria is doing that lovely job of trying to contact these people that are so busy they can barely respond to us, but we're determined to work our way through that and contact all of those people. So you will get an email about that, and we will be asking you to contact Maria directly, who has now got a Life on the Level email address. So thanks again, Maria, for all the hard work you're doing on behalf of the group. Next thing we come to, and this has been quite successful. We started, I think it was sometime last year, it could even be before, WhatsApp groups for certain conditions. By far the most successful one has been a WhatsApp group for people with triple PD. And I'm just going to ask Gaynor if I can find Gaynor. There we go. Gaynor, can you unmute? And I'm just going to bring you. Gaynor, if you could just tell us a little bit of what the group does and really how people benefit from it, please.
Well, what the group does, we're all there to support each other. So we've got over 40 people. Some people have PPPD diagnosed or have it suspected, and we support each other. Just if somebody even needs a virtual hug, or we share odd symptoms, because anyone who has PPPD knows some of those symptoms can be very wide-ranging, and there will be somebody else in the group that has that, so you know that you're not going mad. And I think it's just brilliant having that. So we have regular meetings every month or so. We do some light yoga as well, and we've also got a group who are just on Outlook, and everyone, we meet people where they are. So if you can't use your camera, you're welcome to join on a phone, or you can just join with your audio on Zoom meetings. So everyone is invited to just join where they are. Nobody's forced to do anything. It's all very much just about caring and sharing and giving each other that hug when we need it, because we all need that at some point. So if anyone wants to join the group who has PPPD or suspected PPPD, I'll put my email address in the chat, and you're welcome to join us. Thank you for that, Kevin.
Yeah, brilliant. Thanks, Gaynor. And of course, remember with WhatsApp, you don't have to respond if you're having a bad time, bad day, bad week. You don't have to participate. So don't ever feel you're risking being under pressure by joining this. We have also got they're not quite working as well as triple PD, but the one that does work well, we've got a WhatsApp group for partners of members. And that's all about our partners learning how best to, I was going to say cope with us, but you know what I mean, how best to understand how we are, and the frustrations that not only we have, but our nearest and dearest, when even we don't know if we're going to be up to leaving the house 2 hours from now or tomorrow or next week. So it's very frustrating and disruptive for our partners. So there is a little WhatsApp group there. If anyone wants their partners to look at this, join it, then contact me, and I'll put you in touch with Jean who runs that. And then we are looking for people who want to join a WhatsApp group, not really create that, get it working on many areas, vestibular migraine, And we're open to suggestions if someone has a different condition out there and would like the thought of getting a WhatsApp group going with people with the same condition. So remember, the key here is sharing does seem to have such a positive effect on us. And the fact you can share tips, advice, even just understanding how in this strange world you get exactly the same response as a complete stranger you've never met, but they've both got the same condition. In some ways, it's very heartwarming and helps us all. So don't hesitate to try it. You can always try it and then leave. It's not a problem. Which is, you remember, it's what we say about our balanced sport group. We want to be made redundant. We don't want you here, but while you need the group, while you benefit from it, then everyone is welcome. The last notice, and apologies, this gets slightly political, which we don't do a lot of, but I think we can all blame. Oh, apologies, someone's just trying to get in to the meeting now. They're a little bit late. Steve Watkins, are you still there? Give us a wave, Steve. Yes, Steve. Hi, Steve. It's all Steve's fault. He had a wonderful article in the Daily Mail about balance disorders and using his trike bike. We got so much great publicity from that. Steve went on to hassle his local MP about why can't we make treatment of it better in the NHS, or a lot better. And that led us on to ask all members to contact your MP, and originally it was something called an early day motion, but we've progressed from that, and we're now asking you all to ask your MP, who, shocking breaking news here, MPs work for you, not the other way around. That's what they're there for. We want you, if you've not done it already, and fear not, you'll get an email explaining how to do this. We want you to ask them to write to the current health secretary, who I believe is the third health secretary in 3 months. What that says about our politics, and what we're asking for is, number one, better triage at GP level. Many of you here and many who go on to watch this recording will nod your head when I say you probably had really lousy experience at GP level, because they don't know a lot about balance disorders, and many members report how they are sent away saying it's probably a virus, you'll be better in 2 weeks. And the problem we're getting is they're not able to pick up on serious balance disorders soon enough. So people aren't getting referred to experts such as Professor Rea as quickly as they should. So that's number one ask. Number two, and I'll come and ask Professor Rea to comment on this in a moment. Number two, we've all seen, or many of us will have seen, the dire state of accessing treatment in the NHS. You are either waiting 1 year or more. When you finally get to meet someone, you may get the wrong diagnosis. You may be lucky, you may get the right one. You may then struggle to access treatment for your disorder. So we know at the moment the NHS is not in a good way, but if we don't push for better treatment for balance disorders, no one else will. And what only you appreciate, and people who have never had a balance disorder don't appreciate, it might not kill us, but it really can end your lives as we know it. And that is such a waste of your life, of humanity, of how productive we could all be for our society. So it's just not good enough. And that's why I want to change it. To change it, we believe an answer may well be, instead of diluting the resources across the entire country, where there's too few people, let's focus on maybe a few centres of excellence where you can access the really good experts who know what they're doing with all the equipment. And yes, that may require travel for some of us, which we know is awful. But imagine getting faster access, more accurate diagnosis, and faster treatment. And that's what we're going to ask you to do. If I may just come to you, Professor Rea, for your thoughts on this. Forgive me, the one last thing we're asking the Health Secretary to do is get groups like ourselves to be known by all the NHS departments. So as standard, as soon as you're referred, a patient will be told we exist and we're here to help while they may be waiting. Forgive me, Professor, just your comments on that. And I know it's difficult with politics, but your thoughts on how we should be hassling the government. Is this a good thing?
It's brilliant work you're doing and everyone's doing. I mean, the NHS is really aware of how expert patients are. So it uses expert patients for support, and integrating that is a good thing. We use your leaflets in our private and NHS clinics to try and advertise that you're here. Regarding access, it's really, really difficult. Just as an example, in our clinic in Leicester, I think when I joined, we had 2,000 or something appointments a year. The last time I looked, we'd got it up to something like 7,500 appointments a year. So we've massively ramped it up. When I started, I inherited like 18-month waits, and I managed to get it down to about 3 months in the NHS within 3 or 4 years. We did something really, really good, but it's just completely exploded out of control. And at the moment, we looked last week, we have 1,000 new patients waiting to be seen in the Balance Clinic in Leicester. We have 12-month waits. It's growing every week. This is for new patient appointment. We have 4 or 5 consultants on the case, plus the audiologist, plus associate specialists to try and keep up with the numbers. We've stopped patients being seen on the NHS from outside the county. We've got audiologists seeing a lot of patients. We're trying to innovate with a lot of new ideas. So we're changing the referral forms, because we were finding, and this is really distressing, we're finding a lot of patients would be sent to the open quotes Balance Clinic who didn't have a problem we could treat. Might have been blood pressure or brain or something else. And we've changed, we've now launched a new referral program for the GPs. So I hadn't set the original one up, but my colleague who had is sort of semi-retired now, so I felt able to come in and reformat that. So we hope that that'll be helpful. We're getting the audiologist to see some of our patients without having a medical appointment. So, but I think you're absolutely right. Getting a specialist centre is important, but like the talk, in a way, we're reinventing the wheel. So in 2004, when I started in Leicester, I was part of a group that was asked to work with the government to improve access to balance services. So it's exactly the same question we're asking now. And we worked with the Minister of Health. So we were actually in there with them. And it was agreed, I don't know if you remember at the time, specialist ZARs were sort of all the vogue at that time. So we had balance ZARs. And the idea was to try and set up a specialist balance centre in each area. And what happened was some of these were set up by people who, quite frankly, didn't have any interest, just wanted the name. They didn't see the patients. The people who were seeing the patients had no support. And it just didn't work, and there weren't enough of us. So every bit of push we can give to the government to try and get specialist centres set up, that's what we need to do. Because I think seeing patients with balance problems in general ENT or other general clinics just doesn't work, because the individuals don't have the expertise or the interest in looking after them. Because you have, with a balance problem, a really complex problem, and we can't sort it out in a 10-minute clinic appointment, and it's absurd to try and think that we can. So we are working incredibly hard as far as we can with government, as groups and so on. But I can talk through the challenges of that if anyone's got any questions on it later on. But I think what you're doing is exactly the right thing, and with pressure coming from patient groups, I hope very much that the government will start to listen. But it's going to be slow. And, you know, for example, the NHS facility I inherited 22 years ago, is pretty crummy. You know, the building's really old. They haven't updated it. Well, the good news is that in Boris Johnson's new hospital programme a few years ago, we got an allocation of 40 or 50 million pounds. I think it was 40 million pounds. And then it all went on ice with all the changes of the government. But earlier this year, we got that money. And it's not just for balance, but it's also to knock down a large part of the Leicester Royal Infirmary, rebuild the Children's Hospital, a new entrance, because it's like
Excellent.
the infirmary. It's horrific, isn't it? But we are now building a brand new balance centre. It'll be the best in the UK over at the Leicester General Hospital. And I'm going over to see it next Friday. I've got a day off next Friday, so I'm going to go over and walk round. My office is now 3 or 4 times bigger than the last one, looking over trees, which is very lovely. We're going to have all of our balance equipment over there, all of our staff over there. It'll be easier to park. It'll be easier to access. So we've got a very, very large slug of money, and I hope we can offer a really fantastic service. Whether it speeds things up, that's a different issue, and maybe we talk about that later on.
Yeah, excellent. Thank you very much, Peter. And don't go away, because we're nearly ready for the Q&A session now. Just to finish the politics bit off, fortunately, my local MP, Dr. Luke Evans, is Shadow Undersecretary to Health Department. So his team have agreed to work with us to see what noise and trouble we can make around Parliament. So more of that over the coming months. And don't get me wrong, I'm the first to be hugely sceptical about politics and politicians, but we've got to try, and who knows, good things may come. So I hope all of you here today and those watching this later, let's do what we can as individuals just to try and make that noise. Because remember, the only thing politicians do understand are numbers, because numbers are votes. So let's attack them on their weak spot. Where if they want our vote, they need to start doing things for balance disorders. Right, enough of that. I'm going to bring Claire in now. Let me bring Claire in on the pin there. So we are ready to go through some brilliant questions pre-submitted by members. Don't forget, if you're here today, you can put questions in the chat and we'll try and pull those out at the end of this session. So I'm going to ask Claire, if you can start now, Claire, with question number 1 for Professor Rea, please.
Certainly will. Question that tops all of your sessions. This one's from John and also Julia. Any update on the vestibular implant and when it might be available?
Well, it feels like mastermind, doesn't it? I'm sort of sitting here, having all these questions, sort of anxiously wondering if I can answer them. So yes, I've certainly got an update on that. It's not clinically available. It's being developed in Europe and in America by different groups. A number of patients, in fact, it's exactly the same answer as I gave at the last meeting. A number of patients have been implanted. It's showing interesting promise. It's being much more difficult than we expected, because as you know, cochlear implantation has been the most spectacular medical success, I would say, of the last century. It's extraordinary, giving someone back their hearing. So good you can listen on telephone. And we thought it would be easier to put electrodes on the inner ear on those semicircular canals I was showing you in the last talk and stimulate them. But it's actually proving a lot more difficult technically. So work is in progress. There is some progress being made, but it's not clinically available. So, you know, we are, and it's a really important issue for a couple of reasons. One, the number of people who are suffering from it, from bilateral vestibular failure, that's a loss of balance function in both ears. And it's getting on for a couple of million people worldwide. So there's a big target audience. And it produces these devastating symptoms of oscillopsia, where the world bobs up and down as you walk. But there are some solutions which can be tried instead. Kevin's alluded to one of our patients who's trialed it today. Didn't work for him, unfortunately, but we've had some spectacular successes with other patients with the balance belt, which is wearing a belt with vibrotactile stimulation on it. In fact, we had one lady just a few weeks ago who trialed it and literally walked out of clinic. I mean, it's so wonderful to watch the change in her life. So for the right person, we do have some treatments that can work, but the implants are our holy grail, and we don't have them yet clinically available.
Thank you. Next question is from Brenda. She's had bilateral Meniere's for 32 years and weak muscles in both her eyes. She's bedbound most of the time with no balance. Hasn't had a vertigo attack for 14 years, but plenty of vertigo on head and body movements. So she gets vertigo if she bends over or turns her head too quickly. It's only lasting seconds, but what's keeping her in bed is the lack of balance. She tries to do things when she can, but that's not too often. None of her symptoms have been attributed to Parkinson's. The only symptom she has for that is a slight tremor. She's been back to see her ENT consultant 2 years ago, and they said they can't do anything for balance, and they thought she would just compensate. Is there any hope for her?
Is there hope? Yes, but there are some red flags here that worry me. The first is weak eye movements are not caused by Meniere's disease, and there are a range of different neurological conditions, from myasthenia through to a whole range of other conditions, which can cause weakness of eye movements. And that clearly needs defining by a neurologist or an ophthalmologist, if that's the case. There are some conditions which can combine eye and ear disorders and sensory disorders, numbness and weakness, and they need defining by a neurologist if that's not already been done. The second red flag is having been in bed for a very long time, and that's the thing we dread, because the body deconditions. You only have to be in bed for a short period of time, and you lose your muscle bulk, you lose your confidence, you lose your fitness, you lose your sensory stimulation. Essentially, your body rusts up, and it is actually really difficult to get out of that. The next thing I'd say is it's really important to make sure your diagnosis is correct. Like, you may well have had bilateral Meniere's disease, and that may have left you with bilateral vestibular hypofunction, the condition we were talking about just a moment ago. So the sort of things that we could think about are the balance belt, physiotherapy, general physiotherapy, so getting you out of bed, getting you walking, getting you moving, making sure you don't have vitamin D deficiency. If you're in bed all the time, you'll have very low vitamin D because you're not getting sunlight on you. So there's a whole range of things that we need to think about there. And the other thing I would think about is, was your original diagnosis right? So if you're having episodic dizziness, sure, you've got some hearing loss. Could it be that you had hearing loss and you were having minor strokes, TIAs, even though you've had a normal head scan? Have you got other conditions? So I guess where I would go is make sure you've had a really thorough neuro-ophthalmology assessment. Why are your eye movements weak? Try and mobilize out of bed. Make sure your vitamins, things like vitamin D, are appropriate. And then if you are up and about and vestibular physiotherapy hasn't helped, look at other potential solutions like the balance belt.
Next question from Jan. Just over a year ago, they were diagnosed with vestibular neuritis, and since then they've had permanent dizziness of varying degrees, but every day. 6 months after the first episode, they had a kind of ping and an instant feeling that something wasn't right. And within 20 minutes, they felt the same way as they had the first day. After about 5 days, they were getting back to how they were before, sort of the permanent dizziness state. Another 6 months later, same thing happened again. Every time it comes on instantly. It's not just like I'm having a bad day when things fluctuate gradually. They've ruled out BPPV. They've had an MRI and a CT scan, which has indicated nothing. Can you advise what might be happening to them and what sort of specialists they should see?
This is actually quite a common symptom mix that comes to the clinic, and it's a really difficult one. So when there is episodic dizziness, in other words, the events occur intermittently, it is really difficult to get a diagnosis sometimes because we're not there when the event occurs. We would expect in a clinic like mine to get a diagnosis in about 90% of our patients. Now, the first comment I'd make is you can't rule out BPPV. All you can say is that you don't have BPPV at the time of the assessment. So if you have an acute vestibular neuritis, that virus we showed you with that Hallpike's talked about and Margaret Dix talked about in 1952, that damages the inner ear as well. And you can get secondary BPPV. So over the years, and I showed you the diagram of the inner ear structure, that gets more fragile sometimes because the blood supply is affected to the inner ear, and you can get bouts of BPPV. So that could be what's setting you back. But you could be having a whole bunch of other things causing the setbacks. Vestibular migraine, Meniere's disease, again, TIAs, minor stroke. So you've got to make sure that all of these things have been excluded. But as a general rule with this type of condition, we're looking at really finessing the vestibular physiotherapy program, looking for risk factors, looking to make sure there aren't other things going on. Do you have a history of migraine? That's quite common. And making sure that's treatment for that's optimized as well. But for the great majority of our patients with that presentation, we will get them better over time.
Next question from Angela. How can the GP record a diagnosis of triple PD on their summary record? Apparently it doesn't exist in the list of conditions. Is this because it's known as something else? So now the record says vertigo, which is classed as a symptom, not a condition.
That's an interesting question. If you look up the International Classification of Diseases, PPPD is classified as AB 32.0. So it is a classifiable disease, and it's been since 2017. So I'm not sure why the GP can't do that. So this is definitely a classifiable disease.
And I suspect this is the second part of the question because it's also from Angela. How do they declare triple PD for travel insurance? Because again, it's not on the list of conditions. If you state dizziness or vertigo, it gives a list of possible causes, such as autoimmune inner ear, benign brain tumour, BPPV, malignant brain tumour, Meniere's, multiple sclerosis, labyrinthitis, but not triple PD. They've chosen none of the above as the most accurate answer, but suspect that that's putting the premiums up.
Yeah, again, that's a failure on the insurance company. The only thing you can really do is phone them up and ask them. Now, when you phone up and get an insurance quote, they do put the quote up usually as well. But the increase in fees for balance disorders is usually very, very modest. It's not going to be a major hit, I don't think, to your insurance. But you bring up a very, very good point, though, and that is absolutely essential that you do declare on your form that you have a balance disorder. Because if you go and trip and fall, or you get knocked over, say, in a crowd, and you don't disclose that you've got a previous balance disorder, even though it may be nothing to do with your balance disorder, you won't be covered. And the same with driving. I just do this sort of public health warning, and I tell all my patients with this who have episodic vertigo. You may or may not remember the Glasgow bin driver who had heart disease, didn't declare it to his employer, had a heart attack while he was driving the bin lorry, and I think he killed several people. He was jailed for manslaughter because he hadn't disclosed the fact that he had a heart problem. No sympathy that he had a heart attack. So if you have Meniere's or a condition that might affect your safety driving, make sure you disclose it, because you're safe then when the DVLA have given you permission to drive. And the vast majority of patients with balance disorders can drive unless the attacks are there without warning.
Thank you. Sarah asks, does amitriptyline help with vestibular migraine, even though it's a non-pain migraine, and can it help with triple PD?
Okay, so yes is the answer. I think amitriptyline is a great choice for migraine and even vestibular migraine. Now, the papers on it are not strong. If it makes you sleepy, I'd switch over to nortriptyline. It's a bit more expensive. Start out at 10 milligrams in the evening, 12 hours before you get up. And you can go up to 60, even 100 milligrams. I tend to take my patients up to about 60 milligrams in the evening, see how you tolerate it. It's not that helpful for triple PD. We don't generally use amitriptyline for triple PD. We tend to use the SNRIs and NRIs, for triple PD, which are a different form, much more modern class of antidepressants. They tend to help triple PD quite a lot, and have some help on migraine as well. You've got to be careful taking both the SSRIs like citalopram, sertraline, venlafaxine, and a tricyclic antidepressant like amitriptyline, because there is an interaction called serotonin syndrome. Now, generally, it only occurs if you take high doses of both, but just be aware that whilst you can take both, you'll need to do it very carefully under your GP's guidance. So, yep, I think amitriptyline is a useful drug for vestibular migraine, and for triple PD, less helpful. There is a new kid on the block called the GPANTs, which is a CGRP inhibitor. You've really got to have gone through all the sort of maximum dose amitriptyline, propranolol, and all of those. And if you fail to settle on all of those, you can be prescribed, usually by neurologists, you can be prescribed GPANTs. And there is actually some research evidence supporting their benefit in vestibular migraine.
I'm not sure if this is the same Sarah, but after several years of battling with the NHS, she got a diagnosis of vestibular migraine in 2019 by a private neurologist. He took her off Circ, which is beta-histine, is it?
Sure.
Yeah. After seeing the brain scan, which suggested she didn't have Meniere's. She was also then prescribed candesartan. Been on venlafaxine for 9 years, wrongly prescribed as she feels her symptoms were probably perimenopause at that point. She was then referred for VRT at neuro rehab, had 2 sessions just before lockdown. Since then, she's been battling with the vertigo, and it's been particularly bad the last 2 months. She's been to see a neurologist in London who came to the conclusion that he has vestibular migraine and triple PD. He suggested Dolovent, which she's taking, but has suggested that she comes off the venlafaxine in order to take amitriptyline. She's now on 75 milligrams, which is down from 150 milligrams, which has been a hard change, and she's dreading the next reduction down again. The GP said they can't do a smaller incremental reduction than 37.5 milligrams. What can she do?
Right, that's a lot of information. Let me try.
Yeah, really. Sorry.
So, vestibular migraine, venlafaxine, and amitriptyline and candesartan are both perfectly good. They're all perfectly good treatments. Beta histine is a complete waste of time for vestibular migraine. So for vestibular migraine, we would start with dietary modifications, the 6 C's, Chinese food, chocolate, cheese, caffeine, citrus fruits, and so on. And chocolate, sorry about that. To get off the diet, those stimulants, keep 2 litres of water, make sure you have a regular exercise and sleep program. The candesartan, the neurologist, it's a blood pressure medicine. The neurologists really like that for vestibular migraine. It's sort of the flavour of the month, as it were. Amitriptyline can be really helpful. Venlafaxine can also be really helpful. I think, did you mention perimenopause somewhere along the line? Yeah, I wouldn't be critical of that diagnosis, because the thing is that migraine and vestibular migraine are worse during the perimenopause. So there is this concept of the migraine march. I don't know if I shared that with you all. So the migraine march is really interesting. And if I haven't shared it with you, I'm going to share it anyway, because I think it's a really interesting way of understanding your life. And you go, oh, now I understand who I am. So when you're a migraineur as a child, you'll often get travel sick in the car. You might be the child who didn't like discos and noise. Yeah, so because noise is really irritating and annoying. You might then start to get, if you're a lady, you might start to get migraine headaches after you start having periods. And then you might get better. And then during life, you might have the odd migraine. Then you might get into your 40s and become perimenopausal. Then life is terrible. You fall out with your other half and have arguments, and you're miserable, and you have headaches, and you have vertigo, and every day is a misery. And I always tell my ladies, because it's always in the 40s that everyone comes to see me with this, the rather sunny uplands of postmenopausal bliss. So when the menopause settles, very often the symptoms of migraine and vestibular migraine settle. And actually, you suddenly look back on your life and you find that I was really irritable with this, that, and the other. And now I understand why. And I think that's really empowering to understand why you were like that during your journey of life. So just coming back to your treatment, are you familiar with the concept of a Venn diagram? Do you remember that from school, where you have one circle and then another circle that overlaps it, and maybe a third circle that overlaps it? So triple PD and vestibulopathy and vestibular migraine all are a circle in this Venn diagram. So you can have all 3 elements of it. And it's really, really common to have triple PD and vestibular migraine together, because the symptoms overlap very, very much. And the difficulty there is, we've talked about that amitriptyline helps the migraine, and venlafaxine or an SSRI like sertraline or citalopram helps the triple PD. So the treatments you've been given seem to be rational and sensible. And that brings us on, if I can remember your question correctly, I hope I'm going through this properly here, to how do I come off venlafaxine? Now, generally for triple PD, I recommend 12 months of venlafaxine. That's what the publications have recommended, and then come off it. And most of my patients are fine coming off venlafaxine. 2 of you have had brain zaps coming off it, but they generally have settled in a week or 2 after coming off it. And one of the reasons is venlafaxine's got a fairly short half-life, so its action is fairly short lasting. You can break open the capsule of venlafaxine and take some of the spherules inside just to have a slightly smaller dose. But what you can also do is use a longer acting drug at the same time as venlafaxine. So if you're having real problems coming off the venlafaxine, what I would do is ask your GP whether you can go on to a longer acting SSRI, which is something like fluoxetine, sertraline, citalopram, and run that in parallel with the venlafaxine to protect you, as it were, as you come off the venlafaxine. And then you can come off the sertraline, citalopram, fluoxetine at a later date, because that's a much longer acting drug. Whew. That was quite an answer. I think I've done quite well there, haven't I?
I think you've covered every single aspect, and you may have even answered the next question. On top of her diagnosis of vestibular migraine and triple PD, this is still Sarah, could she have vestibular neuritis? She had several ear infections as a child, and to date, every time she gets a cold, it goes to ears, which feel blocked, crackly, full, gets hearing loss, feels like she's underwater, disoriented, lasts 3 to 4 weeks, she dreads cold season. And then she put the professor, I'm presuming she doesn't mean you here, didn't seem interested in this when she was asking why the episodes of dizziness last so long.
Okay, so there's a couple of things there, which I think is very interesting. The simple answer to your question is yes, but that's not a really very helpful answer. Because the infections you had as a child, you can have vestibular neuritis as a child, which could set you up for triple PD later in life. But it's much more likely you have simple URTI, so upper respiratory tract infections, coughs and colds. The key is they produce pressure and crackling in your middle ear, in other words, behind your eardrum. Vestibular neuritis affects the nerve to your inner ear, deeper in your head, and it's usually a one-hit wonder. Usually only happens once. And triple PD and vestibular migraine are in your brain. So you've got 3 different locations for 3 different conditions. Now, if you've had vestibular neuritis, in other words, you've got damage to your inner ear, any intercurrent illness, i.e. any other illness related or unrelated, will make you feel rubbish. And that might be a cold, viral infection, could be perimenopause, could be jet lag, could be a row with your boss. All of those things can knock you off and you decompensate. So whereas your brain has worked hard to try and get the ears, the brain and the eyes working together again, you become ill and it knocks that off. And it may be, if it's prolonged, you've got eustachian tube dysfunction. It's just an idea. Pinch your nose and blow, you pop your ear. Well, if you've had very sticky tubes all of your life, you might have a funny reduced pressure in your ear. And we all know when we have a cold and our ears are blocked, we feel really miserable, don't we? And if you're predisposed to that, and you've got vestibular migraine as well, that's one potential cause of you feeling rubbish with it.
Great. And Claire, you have a rest for a moment. Have a sip of water. I'm going to just take over asking the questions to you, Professor. This one's kind of related to what you were just talking about, I think. It's from Laura. I seem to get what I call eustachian tube dysfunction immediately after microsuction, which I understand as the hoovering out of the ear canal. I cannot get a proper diagnosis, as has been suggested, as my doctor says there is nothing wrong. As well as having the blocked feeling, what's horrible is hearing my own voice and chewing echo in my head. I also noticed some hearing loss in the ear where suction was difficult. I do not have the jaw joint grinding problem. Am I justified in requesting a referral to ENT? Is there any treatment available?
Okay, it slightly depends on the timeline. So there are tiny muscles in your ear called stapedius and tensor tympani, and when exposed to loud noise, those muscles spasm, so they fix your ear bones. I caught one yesterday intentionally when I was restoring someone's hearing in theatre, so changed their hearing bones. So if it's a short-term muffling, that's nothing to worry about, and that's normal. The thoughts I have, however, that if you're having a long-term sensation of autophony is the sensation of hearing your own voice internally, like you've got your hands on your ears. There are a number of other conditions that can cause that. Yeah, eustachian tube dysfunction is one possibility, but you'd expect that to be present prior to the ear suctioning. The second possibility is when you're having your ear suctioned, I don't know if you put eardrops in beforehand, whether it's causing a cast, if you like, of liquid wax on the eardrum, and they're not fully cleaning the eardrum, so you've still got this weight of liquid wax or debris on your eardrum. That would be a simple solution. You can have middle ear problems, so we're now going behind the eardrum, and there are conditions like otosclerosis, glue ear, a whole bunch of middle ear problems which can cause it. And then there's one very interesting condition which presents in this way, which won't have been looked for, and that's called superior semicircular canal dehiscence syndrome. A bit of a mouthful, and this is one that was first diagnosed or suggested by Lloyd Minor in America in the late 1990s, I think. And this is where the superior canal, which is the upper balance organ, the bone between it and the brain thins as you gets older. And if you're born with it very thin and then it dissolves, you get what's called a third window. So you get this sensation of hearing your own voice in your ear, which is a very long way of saying, yes, I think you should have an ENT referral.
Yes, very good. If
someone who knows what they're talking about, so to an otologist,
yeah, super. Then I've got a personal question here on this theme. I fly probably too much, but still enjoy flying. Flying, by the way, to everyone out there, does not affect my balance issue at all. But I believe it's called something along the lines of barotrauma, where I've got one good ear, the bad ear with many ears, but the good ear, that's the one thing that still 20 years on spooks me, the thought of the good ear and hearing ever being lost there. For 3 days following one flight, I had massively reduced hearing on the good side. And all I can describe it as was the effects of the ear popping when descending in the plane didn't go away for 3 days.
Okay, so that's a really good question, Kevin, and it's something we see really commonly. So an international cosmopolitan jet setter such as yourself, who's flying business class every other day around the world, might want to put you can have a long-term grommet. So the cure that I put in business folk, or sometimes my patients who have just retired and they're spending a couple of years traveling the world, or a couple of decades in your case traveling the world on the proceeds of your exceptional business adventures, might put a long-term grommet in. So that's option one. Option two is you can try some xylometazoline, so Otrivin spray. So squirt that up both nostrils for 24 hours, as long as you don't have a heart condition. Squirt that up both nostrils for 24 hours before, an hour before takeoff and an hour before landing, to try and open the tubes. And the third one, interestingly, was some research I was involved in 25 years ago. So I spent a day in the business class lounge at Heathrow Airport, and my colleague spent a day in the business class lounge at Schiphol Airport in Amsterdam. And we had about 500 patients, so we took 2 or 3 flights on BA, flying each way. Every single patient, that's not true, sorry, half the patients, they're not patients, half the travellers, we gave something called the Otovent balloon, and half we didn't. And we measured their pressure in their ear, and we looked at the ears before takeoff, and we looked at the pressures afterwards. Now, we know from international research that about 12% of people experience barotrauma, which is pressure in the ear on air travel. So you're in good company there, and you're more likely to experience it if you've had ear problems in the past. By using the Otovent balloon, it reduced that to 5 or 6%. So what this is, for those of you who don't know the Otovent balloon, it's a little nose piece you put in, and you blow up a balloon. We did have a slight problem that a few people refused to do it because they thought they were on game for a laugh, blowing up a condom on the flight. But that's another story as well. But most people did engage in this study, and it was really fabulous because most barotrauma, yours would have been grade 2 or grade 3 barotrauma because you had fluid in your ear afterwards, and that's a highly significant degree of damage. We didn't have anyone rupture the eardrum, but you can rupture your eardrum on air travel as well, and that's highly, highly significant if that occurs. But using the Otovent balloon will, on descent, absolutely on descent, not ascent, to try and pop the ear and equalize the pressure. And using xylometazoline before is probably the most sensible way to do it. And if you are jetting around the world on multiple flights, so a lot of people, when they retire, will go and see family in New Zealand or Australia and have 7, 8, 9, 10 flights over a 3 or 4 month period. If that's the case, it's probably safer putting a grommet in to protect the ear over that period.
Very good.
And I can just see Angela popping up here. Hi, Angela. You couldn't blow the balloon up with your nose. Do you know what, Angela? Neither could I. But most, I don't know why I couldn't do it. I tried it, but most people do seem to manage it. Look, you can only try, can't you?
Good. And I must add, it's only happened the once in my life with many flights, so it's not. Yeah, I don't think it's that common for people. Great. Next question is anonymous from one of our members. Why does it take so long to access treatment for a balance disorder? I'm in the north of England and I've been told I may wait up to 18 months to see a specialist in ENT. What are the reasons for this situation, please?
That sounds like the simplest question of the day. It's actually the most difficult and perhaps the most important question of the day. So thank you for asking that. And as Kevin alluded to earlier, this is something that's a historic problem over decades in the UK. And there are several answers to your question. And it's not through, I don't think it's through lack of money, and I don't think it's through lack of trying either. But I'll give you several reasons why you're experiencing this delay. The first is a lack of clinicians with adequate interest or expertise. Seeing someone with balance disorder is really hard work. So I go home completely exhausted and collapse on the sofa as soon as I get home, because it's actually draining. Because it's not, I'm going to be really rude to my orthopedic colleagues here. It's not like going in and saying, yeah, you got a broken bone, let's stick it back together. Because balance disorders can arise from any part of the body, not just the ear, the eyes, the brain, the sensation, the heart. So you're thinking about everything. And there's a huge emotional burden as well with psychological burden with balance disorders, as you will all know. So as human beings, doctors find that really hard work. And if they don't fully understand it, it's really stressful as well. Now, when you're in a position of privilege like I am, who's having been doing it for 30 years or so, and thinking I know a reasonable amount about it and having some confidence with it, for me, I really enjoy it. And I love seeing my patients with balance disorders. And I hope I can get most people at least somewhat better. And from my perspective, I go around lecturing on it. I've tried to get these set up, especially centres around the UK and so on. But the first answer is it's a lack of specialists. The second answer is all of our fault. Now, I suppose it's not really our fault, but all of us are getting older. And the population is getting a lot older. So if you go to a Middle East country where there's a very young population, or an African country where the average age is 25 or 30, you won't have significant balance disorders in the population. But if you come to the UK where we have an aging population, you really do. And then we introduce the next concept, which is lifespan. Now, our lifespan up till the last decade or so has been expanding. But you'll also, I'm sure, have read about the concept of health span. And that's how much of our lives do we lead in good health. And you might be surprised that in some areas of the country, health span is only till the early 60s. And by that time, the majority of the population have a number of other illnesses making them unhealthy. In wealthier areas of the country, it might be into the early mid-70s. But in the balance clinic now, we have many people who I welcome in their 80s or even 90s who are saying, well, I just can't do what I used to do, doctor. And, you know, in the past, well, hang on a moment, you're 80, 90, whatever. What would you expect? But the expectations of the population have changed now. So we're getting the third thing in, which is complexity. And that's the third problem, that there are two ways of viewing a balance disorder. You can either say, my patient's a bit unsteady, let's give them some physiotherapy, a walking stick or a wheelchair. Or you can say, and this is what society wants now by and large, my patient is dizzy, what is the cause of that dizziness? And that's how we'll work in a centre like mine. And we'll say, is it an ear problem? And if so, which one? Is it a brain problem? And if so, which one? And then I find a problem, a bit of aging on the brain. So you need an MRI scan, then you might need carotid duplex scans, then you might need a bunch of blood tests, then you might need a heart imaging. And then I need to look for sensation problems in your feet, and you might need blood tests for that. Da-dum, 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 da-dum. Then you might need to see a neurologist, cardiologist, respiratory physician. So do you see, the problems as we get older are multifactorial. So balance is not usually one problem. It's multiple different problems contributing to the balance disorder, which is why many of you haven't got better, because it's not just the ear. It might be the ear plus the brain plus loss of sensation plus this, that, and the other. So we've got increasingly complex balance disorders, which take up a huge amount of medical resource to establish a diagnosis and try and treat. A lack of clinicians and an aging population. And essentially, the health service can't keep up. And I gave the example when Kevin asked a similar question at the beginning of this session, that when I joined in Leicester, we had, I think, just over 2,000 appointments. Now we have 7,500, and we've still got 1,000 people on the waiting list. And we've stopped people coming in from outside the county to the NHS. So we're working our socks off, adding in doctors and resource and everything else, but we're just not keeping up with this flood of increased demand that the population is sending to us. So there is a real reason, but that's not an excuse. And because there are regions of the country which have absolutely no resource to balance disorders. If you're in Leicestershire, you have amazing facilities, difficult to access because so many people want to access them, but amazing facilities. In one of our neighbouring counties, they have nothing. There is no testing facilities at all or treatment. So it's very idiosyncratic. It's different. It'd be very interesting to see what Maria finds when she's done her work, and I really look forward to that, Maria. Thank you for doing that. It's really difficult, and you've raised a very, very important point. So thank you.
Good. Yeah, lovely. Great answer. Thank you. Next question is from Marcia. I have damaged cranial nerves, vestibular, cochlear, vagus, and accessory, and dopamine secretion due to a jugular tympanic, can't even begin to say this next word, paraganglioma.
Yeah.
For which I had gamma knife stereotactic radiosurgery in February. I have been doing vestibular rehab since the end of April, but so far have no improvement to my vestibular system. Pulsatile tinnitus and sensorineural hearing loss, vestibular hyperfunction. I would like to know if there is any research in this field and if there is any hope of improvement for me in the future.
Yeah, no, absolutely. I'm sorry with your diagnosis. So paraganglioma is usually a benign tumour that affects the sort of big blood vessels as they come through the ear or drain through the skull base into the neck. And your paraganglioma has picked off the hearing nerve, the balance nerve, the nerve to the shoulder, and the nerve to the throat. So it was presumably quite a sizable tumour. Now, and that will cause the hearing loss and the tinnitus and so on. Now, you've had stereotactic radiotherapy. So gamma knife is an external beam radiotherapy. Rather than cutting it out surgically, if you have it surgically, you can lose all those nerves in the skull base. It's a very, very difficult area. It's probably the most difficult area in the body to operate. Now, the thing about radiotherapy is it's effective in treating these tumours. It shrinks them down and often stops them growing. But it might damage the neighbouring brain. So that's the first issue. So although the gamma knife focuses the radiation very carefully, you can get some spillover into the brain around it. And the brain around it's the cerebellum in your case. And that's the balance part of the brain. And that's quite difficult to treat. So that's the sort of the negative part of the talk. But the positive part is it's taken out your balance nerve. So this has definitely got a peripheral vestibular component. In other words, it's got an, if you like, an inner ear balance component. And that responds really well to therapy. Now, the tumour will swell initially with the radiotherapy, and then it will shrink down and scar down. So there's still some activity in there. And you've only been doing treatment for a few months. With vestibular physiotherapy, we don't expect to see progress until 3 months. And maximal benefit can take 12 to 18 months. So you're very, very early in your therapeutic journey. You need to be under the care of a specialist vestibular physiotherapist. Make sure you just haven't been given a sheet of paper that you're following. I want you to be under someone who knows what they're talking about from a rehab perspective. And almost certainly you are, because paraganglioma are operated in specialist hospitals who usually have very good vestibular teams with them. And you'll need to be doing the exercises 3 or 4 times a day, and you'll need to be doing them for 12 to 18 months. Now, I can't tell you what the outcome is going to be, but the majority of our patients will be expected to have a very significant improvement over a period of 12 to 18 months. So please don't give up hope.
Brilliant. Good. And that is a message to everyone. Never give up hope. Things always do get better. Next question.
Kevin, I would be careful on that. Most people get better. I think we've got to be honest with ourselves.
Yeah.
Can get most people better.
Yeah. For the members, we tend to find, even if symptoms don't, the better bit, the better element is the understanding of the condition, the reduction in fear, and eventually coping with life. The way I put it, what happened to me, which I know many as is if you like, a more straightforward condition, I got to a stage where instead of the condition running my life, I managed to get back in charge of my life. So we refer to getting to a better place. It's strictly non-medical, but it works, and I assure you, most members we do get there. Yvonne asks, is a diagnosis of triple PD just a name given to this condition when all tests have failed to find a cause for my dizzy symptoms?
I can give you 3 answers, and they all begin with N and end in O. No, we absolutely hang our head in despair with any clinician who uses triple PD, persistent postural obstetric dizziness, as a bucket diagnosis for those they can't diagnose. No, triple PD is a very specific label. Now remember, it's not a pathological condition like a broken bone. It's been put together with a symptom complex that brings together a number of other previously named conditions. And essentially, it's a central processing disorder of balance. So it's when your brain is handling sensory information, particularly from the eyes and ears, incorrectly, overutilizing particularly visual stimulation. So you struggle with patterns and motion around you in supermarkets and scrolling on the phone. Now, you may well have a normal set of balance tests, but that does not include or exclude the diagnosis. So answer, no.
Very good. From Yvonne again, how can we get effective treatment when it's so hard to get a diagnosis and follow-up?
Yeah, I think it's a very fair question. And it really reflects back to that question about access to balanced services. You need to see someone who knows what they're talking about. And again, it's a real heartache for someone, or heartbreak for someone like me, when people are seen and given clearly the wrong diagnosis, and equally not given aggressive enough treatment. So triple PD is a very specific diagnostic label. So the first thing is you have to have the diagnosis right. And our patients will usually have a history of 1, 2, or 3 of a vestibular event, BPPV, vestibular neuritis, migraine, and stress and anxiety. So you might have 1 or 2 or 3 of those in your history. Not always, but most people do. And we have really very specific treatment pathways for this, both medication and a variety of different types of therapies.
There you go. And Yvonne, by the way, she has commented, one appointment with an ENT after a wait of 18 months. Said I probably had triple PD and possibly vestibular migraine. It also said, despite having a hearing test that showed symmetrical hearing loss, that I could have atypical Meniere's disease. He discharged me back to my GP with a prescription for beta histamine and a request for vestibular physio. My GP knew very little about any of these things, and there was no vestibular physio available to me locally. Familiar story.
Not too impressive, is it?
No. And I say, sadly, this is what I hear almost monthly, Peter, of the disconnect, the disjoint, and our lives suffer while this goes on.
Yeah, I'm sorry, and I agree. So beta histine is a waste of time for triple PD and for vestibular migraine, and it's questionable. Some people with Meniere's do find beta histine helpful, and I keep people on it when they find it helpful. But the majority of the research doesn't support its use. We don't use it that often now. The vestibular physiotherapy, you need to be seen by a specialist vestibular physiotherapist, not just given a random set of instructions from the internet, because we know that generally doesn't work. And the diagnosis needs confirming, and you need to have some certainty about the diagnosis. So I find that entirely unsatisfactory.
Okay, and then the final question from Yvonne. Do you think varifocal glasses should be avoided if you have triple PD?
Very good point. Thank you for bringing that up. Yes. And the answer is because you're often visually dominant with triple PD, and indeed with vestibular migraine, having the visual element of the sensory input from your eyes disrupted by the varifocals is often challenging. So I would use reading glasses and distance glasses. Yeah.
Super. Question from Simon. As science and research improve and embrace AI, is there hope of discovering that these conditions have underlying biological or genetic causes? And how does that open up targeted options for treatment?
Oh yeah, for sure. I mean, quite a lot of the conditions have genetic causes. So for Meniere's disease, 10% of patients with Meniere's have a first-degree relative with it. I led on the 100,000 genome project in the UK for Meniere's, which is where we looked at the entire DNA mix of 100,000 people. We couldn't get a genetic link in Meniere's, which was interesting. But there are some conditions where we definitely know there are genetic links. Now, there's one of the rare conditions I'll think about if I see you with intermittent dizzy spells is a condition called episodic ataxia type 2. It's a rare genetic condition of the CACNA1A gene, if you want to be technical about it. But this is a calcium channel gene in the brain. And if you're given acetazolamide, which is a mountain sickness drug, it cures you. I've had a few patients with that. But what's really interesting about CACNA1A is that it also codes for other conditions like spinocerebellar ataxia type 6, which isn't that interesting to you, but it's a condition that causes progressive imbalance, but also for hemiplegic migraine. Now we're getting really interesting, aren't we? So migraine produces a whole bunch of symptoms, not just headache, not just vertigo. 10 to 10% of migraine attacks produce spinning. It can produce knee pain, recurrent abdominal pain, produce paralysis, and hemiplegic migraine produces paralysis down one side of the body. And that is a genetic condition. So the answer to your question is, yeah, I think we will progressively find more genetic conditions presenting to this. There are a group of rare conditions we're very aware of, and we now have genetic panels that we can send off, which are funded by central government, not just for sensory neural hearing loss, but for episodic vertigo as well. So that is work ongoing, and that's moving forward quite quickly, actually.
Super. Thank you very much. Question from Sue. I've been on venlafaxine for several years now, and I'm wondering how long I should be taking it. And who do I need to see to discuss this? Is it my GP or a consultant?
Oh, your GP should be able to reduce it. It slightly depends what you've been on it for. If it's for triple PD, you should certainly come off it now. I mean, I normally recommend a 12-month course of venlafaxine. There are other conditions, severe depression and so on, where they may feel the risks of taking it long-term outweigh the benefits. There are risks of venlafaxine in the long term. You can get emotional blunting, so you can not feel the person you were before. It sometimes affects your blood pressure, your cholesterol, and various things. So it's not necessarily a drug you want to be on for a long time, but it's definitely not a drug you just stop. That would be catastrophic. You have to work with your GP. You have to come down very, very slowly on it. Depending on the reason you're on venlafaxine, you may or may not wish to substitute it for another drug like an SSRI that we mentioned before, citalopram or sertraline. Or if you struggle to come off it, you might want to phase in an SSRI as you phase out the venlafaxine. We don't do that very often at all, but that's a possibility. So no, you definitely, it's your GP you see about coming off venlafaxine. And unless there's a very good reason that you should still be on it. If you've been on it several years, I would recommend coming down on the dose and if possible stopping it.
Lovely, thanks. Question from Conchita. How does triple PD how does it start, or sorry, explanation of how it started, and does it get better after 6 years? Is there any hope for me?
Oh yeah. So as I mentioned on one of the previous answers, triple PD usually starts with an acute vestibular event. So you might have a vestibular neuritis, you might have a head injury, and might have Meniere's disease, might have BPPV. So something injures the balance organ. And our patients who develop it have a very specific personality type. So for example, my son's on a couple of research projects he's had published, where we can actually do a card game, a card trick with you. And depending on how you respond to these card games, you can predict whether you might get triple PD or not after an inner ear injury. So there's a certain personality type that gets triple PD. And often it's on a background of migraines. There's a lot of overlap between migraine and triple PD, and with stress and anxiety in the past as well. So those three things often go together. So that's, yes, there's a trigger. And then that triggers the brain to mishandle sensory information. So if you imagine you get pulses of information from your eyes, from your ears, from your joints and the rest of your body, all goes to a sort of a central RAM, if you like, in your brain, the vestibular nuclei that processes the information, but it mishandles that information. and that gets into a vicious cycle that's difficult to get out of. Overall, we get 80% of our patients better on treatment. We also find if we treat people even late, after 5-10 years of symptoms, we still have about an 80% success rate in getting the better. So there's a lot of hope there. And we talked about the medications, therapies, and dedicated vestibular physiotherapies as well. And combined together, whilst we don't get everyone better, we get the great majority of our patients better. But I think, you know, the first step always is make sure it's the right diagnosis.
Super. I can imagine our WhatsApp group for Triple PD is buzzing with what sort of personality character am I? Maybe after the meeting, if there are any links to where they can learn more about that study, would be very interesting. So I know it was suggested years ago for Meniere's of whether there were certain personalities with Meniere's. I personally don't believe it after meeting so many people, but on the Triple PD, it'd be very interesting if we can get any links to any work there, because I can imagine our members with Triple PD would be very interested there to
just Google it.
Yeah, okay, yeah, we'll try AI Google for Triple PD characteristics.
But look up the research, not forums.
Okay.
Yeah.
Understood. Next one, Julia. I would like to ask Professor Rea if there are any updates on vestibular implant trials.
Well, yeah, so as per the first question, not in the UK at the moment, no. They're being done in Europe and America, but we're not introducing people to them in the UK at the moment. Sorry. We're actively engaging with people, but they're just not far enough advanced for us at the moment.
Okay, thank you. From Richard, can Professor Rea please offer as much advice as he knows about NDPH, New Daily Persistent Headache, which I confess I had not heard of, since there's not much help or information out there?
So, yeah, so daily chronic headaches, generally diagnosed when you have headaches most days for 3 months or more. It's really outside the remit of ENT. That's really a neurological problem. And when patients get chronic daily headaches or new daily headaches, we tend to refer to neurology. I mean, the first thing is to make sure there's nothing else causing it. So you tend to get an MRI scan, make sure there's no other diagnosis of it, neck pain and so on. And the treatment modalities are generally amitriptyline to start with, pregabalin would be a second medication, and nerve injections, occipital nerve blocks and so on. They're the three main treatments for daily headaches, but that's really outside the management of ENT and it's really a neurology.
Okay. I mean, Richard just mentions there alongside he's also got vestibular migraine and Triple PD. Would that affect your recommendation of approach?
It will do, potentially. And the reason is that when you have vestibular, if you have migraine, if you're a migraineur, every symptom you have is accentuated. So everything is worse because migraineurs, as I'll tell all my patients, are advanced human beings. They're much more sensitive to sensory change, whether it's weather change, so I think there's an evolutionary advantage on it. Don't quote me outside the group on this. This is just, anyway. There must be a reason that 15% of us have got migraine. And it's an evolutionary thing. So with crop rotations and I don't know. Anyway, the thing is with migraine in the modern life we live, we are bombarded with sensory stimulation and it becomes really, really difficult. It doesn't matter if it's your phone or your computer or traffic or shops or whatever. So that's really difficult with migraine. And Triple PD as well. So difficult one, sorry. But the thing about having that additional sensory stimulation tenses you up. So you don't want to move your head because that additional sensory stimulation from the ears is unpleasant. So you hold yourself more stiffly and then the occipital neck muscles tighten up and that contributes to headache. So that's why sometimes occipital nerve blocks can be helpful with chronic headache.
Super, thank you. Jackie asks, how big a part does stress play in Triple PD and how? Even good stress, like arranging a meal for relatives or friends, can make me overthink, desperately disorientated, lightheaded, and I've had to cancel and then sleep for hours.
Yeah, I mean, that's a good point. And the answer is yes. There's no question. Stress is a big part of triple PD for some patients. And you're also absolutely right that stress can come in lots of different forms. It can be stress because you're stressed about a bad thing, be stressed because you're psychologically stressed about a good thing, or it can be a physical stress. You've jet lagged, you've not slept, you've got another illness. So all of those are stress, and the body responds to stress in similar ways. It produces cortisol, fluid retains, and then you get all of those sort of physiological, biological consequences of stress. So it's a biological human reaction, and it's certainly part of triple PD.
Okay, lovely. Sylvia asks, I was diagnosed with having triple PD and left-sided triple PV in March 23. Okay, I was advised to have Zoom calls with vestibular rehab clinicians, but at the time none were available. Should I consider venlafaxine or sertraline or physio exercises or both, as my vertigo has gotten worse?
Okay, so that's a good question. So sorry you were lost in the system there. But the first thing to do is see someone to make sure you don't have BPPV, the crystals. Because if you've got crystals, nothing else is going to get you better. And you may not be aware you've got them, because what happens when you have BPPV, the crystals in the air for a long time, is you develop coping strategies so you don't get into the position that triggers the BPPV. You might use an extra pillow, stop rolling over and stuff. So make sure you don't have BPPV. And then see someone with expertise in triple PD, persistent postural perceptual dizziness, and get the 3 strands of treatment in place. So discuss medication, which might be SRI, like sertraline or citalopram, or an SNRI, like venlafaxine. Get a really proper vestibular physiotherapist to manage your balance, and then think about CBT. So do proper treatment of both strands of your condition.
Lovely, thanks, Peter. I'm going to hand back over to Claire, who can read the questions correctly and pronounce everything. I will take a breather for a minute. Over to you, Claire. Thank you.
Question from Ali. Can you tell us anything about normal pressure hydrocephalus and its effects on gait and balance? They're waiting for surgery for this condition and want to know if vestibular exercises would be any use prior to surgery.
Yeah, so again, this is a neurosurgical problem rather than a neurological or vestibular problem, but it's something we see not infrequently in the balance clinic. So normal pressure hydrocephalus is where the fluid volume of the brain expands. The pressure stays the same, but you get loss of brain volume as the fluid expands within the brain. And you can have, it just happens, or sometimes tubes can get blocked to make it happen. And it's very much a condition of aging. So it's much more common when you're older. And the 3 sets of symptoms are the way you walk is different. So you walk with a broad base gait, and we call it a magnetic. It's like the feet are glued to the ground. Our patients often get urinary incontinence, so that they wet themselves at times, and their memory tends to deteriorate with it. And there's a real population problem here, because if you go into a nursing home, you'll see a lot of people with frames walking like this, and there's a smell of urine in the home. And a lot of that is normal pressure hydrocephalus. Now, we can't operate on the whole of the population with this, but you can put a shunt in, a ventricular peritoneal shunt, to drain the fluid from the brain down into the abdomen, which releases the pressure. And that's been done more and more. And so good luck with your surgery, and I hope it makes a real difference to you. Does vestibular physiotherapy work? I mean, not really. We don't really use vestibular physiotherapy for normal pressure hydrocephalus, because it's a neurosurgical problem that we hope very much will get better, or significantly better, with your neurosurgical procedure.
Next question from Lindsay. The GP has prescribed prochlorperazine for times when they're dizzy and nauseous or when the vertigo is starting. But they've read on the leaflet this medication is not for over 65s, and Lindsay is 71. They asked the GP for something to replace it, but when they collected it from the pharmacy, it was simply the same medication in a different form. Would they be better off taking beta-histine that they were previously on, or should I ask the doctor for something else?
Okay, so it's a really important point you raised there. So prochlorperazine or Stemetil or Bucostem is a really good treatment for acute vertigo. So if you have a really bad dizzy spell, take it for a few days, really good medicine. Long term, it's a really bad medicine to take for 2 reasons. The first is it stops vestibular adaptation. So it turns off your balance system and it stops you getting better. Secondly, particularly if you're older and you take it for a long time, it can produce symptoms of Parkinson's disease. So you can get the shakes and unsteadiness. So we would really not want you on this medicine long term. Secondly, should you go on beta-histine instead? Very, very unlikely. Beta-histine is marketed for Meniere's disease. It's not that helpful for most people in Meniere's disease, so it's very unlikely that beta-histine is going to help you much anyway. Could you have a different medicine to help you? Well, possibly, but it does depend what the cause of your balance problem is. So generally, we would encourage vestibular physiotherapy as the treatment of choice. You can use Cenarazine, Stugaron in the short term as well, and there are alternatives as well. But as a general, you've got to know what the diagnosis is to treat it. And we generally try and avoid medication for most chronic balance conditions.
Question from Sam. They've suffered with vestibular issues for 15 years, but their balance isn't actually too bad. The symptoms seem to overlap with triple PD and vestibular, mainly focusing on objects that are still, fatigue, and intense tension or pressure. Are there other diagnoses they can explore? So I read that word for word. I'm not sure.
Again, it's a good point. It's again this Venn diagram of overlapping symptoms of vestibulopathy, maybe triple PD, maybe vestibular migraine, and having elements of each of them. So you need to get the diagnosis right first of all before we know what treatments there are to explore. And what you're describing in your piece there is there's a very powerful stress element, and we have to reflect that some balance disorders are purely anxiety and stress related. Some are stress related plus an underlying vestibular disorder. So it might be worth thinking about medicine that works on both your stress element and your balance. And treatments will include, we go back to the same drugs, sertraline, citalopram, the SSRIs, and that might be something to think about with your GP. And if it's very, very high levels of stress you have, in some of our patients it's off license, but I use a very low dose of clonazepam, which is benzodiazepine. You may have heard of drugs like Valium, diazepam. I think Mick Jagger called it Mama's Little Helper, if I remember. But this is a sister drug, which much shorter acting, clonazepam. And it's licensed for panic disorder, but you can use it in very low dose for if anxiety is a very, very large part of the balance disorder. So there's a range of drugs that we can use, yeah.
Hey, good question here from Rachel. She has triple PD, recently had root canal work done before the triple PD, but when she goes to the dentist, it gives a dentist-induced BPPV. She now needs further work done on the same tooth, and she's concerned about it triggering the BPPV. She's only had the BPPV once on top of the triple PD and couldn't stop vomiting. She's concerned that if she's sick in the chair, she could choke. Obviously, she'll be laid back for the procedure. The dentist is trying to find a way forward. General anaesthetic has been suggested because the vestibular physio says you don't feel nausea when you're unconscious, but the dentist has said she doesn't fit the criteria for general anaesthetic. Sedation has been suggested, but they don't know if it would cancel enough of the spinning sensation that's triggered with the BPPV. Do you think sedation would help?
What I'd say is I'm really, really sorry you've got a head dentist. I hate going to the dentist as well. I try and avoid it as much as I
can't even imagine it though.
Yeah, I remember I shouldn't really be telling you this, should I? I didn't go for 30 years. And my dentist said, "Oh, you've got really fantastic teeth." And I thought he was about to say, "You've clearly looked after them really well." And he just said, "Well, you've also got good genes, haven't you?" Which I thought was really unfair because I've cleaned them so hard for all these years. Anyway, so sorry you've got to have some work done. And if you get BPPV with your dental work, that's really horrid. And it is a classic triggering position. All I can say is that the dentist doesn't want to do it, but you need to be sat up as high as you can when you have your dental work. It's painful on the dentist's back, but that's what they have to do. They have to get the chair up as high as they can so they're not uncomfortable, maybe do their work sitting down. Get you up, head up as much as you possibly can so you're not lying flat to trigger the BPPV. Should you have it under general anaesthetic? No. Are you going to choke on your vomit? No. Because if you warn the dentist of your predisposition to vomit, then the thing to do is have a vomit bowl next to you, and if you feel you're going to be sick, you just roll over and you'll be sick. So you're not going to choke on it, you'll be safe. Can you have sedation? Well, I mean, yes, I suppose you can. It's not going to stop BPPV because that's a physical thing. And you could have a something like diazepam, sort of sleeping tablet, just to take the stress off the whole experience. But for my patients with BPPV having dental work, almost always we get around it by sitting up as much as the dentist back can tolerate and just coming to a compromise for you there. I've not had anyone who ever needed to have a general anaesthetic. Good luck.
Next question was from Debbie, but she's kindly said we don't need to answer it because you've already covered it. It's another one about the phenylphthalein.
Okay.
The one after that is from Sandy. They have triple PD and a lot of anxiety going any year is a challenge. I've read NHS reports from Lanarkshire and Dorset on the subject, and they've suggested SSRIs such as sertraline. They've begun taking it, but doctors say there'll be a slow progress. Have you seen any results to show it assists with brain reconfiguration for balance issues?
Oh yeah, no, absolutely. So the combination of CBT, vestibular physiotherapy, and drugs like sertraline, we get 80% of our patients better. So absolutely yes, yeah. So there's hope on that one, definitely, even if you've had it for a long time. But again, I come back to what I've said several times, you need the right diagnosis. It's not a bucket diagnosis.
Okay, strap yourself in for this one. Another bit of an essay question.
I'll try and remember it.
Jan, they've had a permanent balance problem every day for the last 33 years. Started after fertility treatment when taking the drug Clomid. At first, it was difficult for doctors to associate the problems with this, but as they'd never had problems before, never even having a cough or cold, so they were finding it hard to understand. They were sent down the road of ENT, neurology and ophthalmology, and had an MRI scan, caloric test, testing for BPPV, all came back as normal. So an ophthalmologist relayed the problems to him and how it had all started, having read that similar conditions are presented with women in America, and this was published in The Lancet, I think. He sent me a copy, and I thought, at least I'm not imagining the way I'm feeling. The question is, have you come across anyone in your clinic with the same problem? I don't spin or have bad dizzy spells. I just have this permanent feeling of imbalance, which has totally affected my life, and I'm still learning to live with it even after all these years.
Okay, so again, sorry you're feeling like that. Clomid, for those of you who don't know it, is it's a stimulant that works on the brain to stimulate the release of eggs from the ovaries, essentially. Now, it is a drug that can produce dizziness in the short term, over days. I'm not an expert on fertility medicine, but it's not a drug we normally associate with long-term dizziness. So I don't know the Lancet paper, I don't know the details of that, but I'm not aware, I've certainly never seen a patient who's had long-term dizziness after Clomid, that's for sure. And the question really is there a condition as a medic we're not familiar with? Really one of the reasons for giving you that talk at the beginning today. Or is it something else that's causing this? Because, you know, it's a very stressful time going through fertility treatment. And remember, 5% of the population have a vestibular disorder in any 1 year. So you can have a coexistent disorder. And again, I don't know the Lancet paper. I don't know the research that was done behind it. But one has to be very, very careful gleaning data from forums. Now, forums such as Life on Level are incredibly helpful for supporting patients, but it's more challenging diagnostically because we always, as humans, try and make an association. It's the classic, if I'm sick after eating a red berry, I don't eat a red berry again. So it's drilled into us in evolutionary survival. And if we began to feel dizzy after taking a drug, we associate that dizziness with the drug. Now, I'm not saying it's not that drug. I'm just saying that I don't know any evidence that it is that drug. And I would have thought exploring for other potential causes and revisiting your diagnosis would be a helpful thing to do. And seeing whether some long-term conditions, such as triple PD being one example, or chronic migraine, or other conditions might be contributing.
Thank you. Question from Jane. She's read about the balance belt. What conditions and symptoms could be helped by this device, please?
Yeah, that's a really nice question. So essentially the balance belt was developed for bilateral vestibular hypofunction. So we started off doing the research with hats on, which had little vibrators on either side and little vibrators in the mouth as well. That was initial research. It was interesting, but wasn't massively successful. And then there's a company based in Europe it's a small company, but really, really nice people run it. And you wear a belt, like a sort of a wrestler's victory belt, around your waist, and it's got vibrotactile sensors and stimulators in it, and it senses where you are in space and tells you to move against it. And some people, like the gentleman who was in the Daily Mail, who just, if you're still listening, you are the most amazing human being. I just want to tell you, I still am endlessly impressed by all the efforts you did for yourself and for others. It didn't respond to it, and some people don't get better to it. Yet we had another wonderful, wonderful lady who's just bought one from the company a week or two ago, who it's completely changed her life. And so it's primarily, and she's out playing golf now with it, and she could barely walk before. I mean, it is extraordinary for the right person. And it's been designed primarily for those who have lost balance function in both ears, bilateral vestibular failure. It's more difficult if you have other things going on. You have a peripheral neuropathy, you've lost sensation in your feet, or other balance disorders. But I suspect over time it may widen its remit and be used in those maybe with really bad balance function on one side, or reduced rather than absent balance function. So it's a really interesting development, but like all science, it's early days and we have to see how it pans out in the long term.
Super. If I can just mention, Professor Rea, Claire, I've just put a link on the chat. Balance Belt Company kindly have offered a free balance belt with the supporting clinician work to a member of the group, but to qualify, they would need to be on PIP benefits already. But they have offered discounts to members as well. But as you said, Ed, I know it's quite a narrow definition of who would benefit from that device. But I can reinforce what you said. I've dealt with the Balance Belt Company for a year and a half now, and they're lovely people. So anyone who's interested, look at our website, and you can visit the Balance Belt website as well. Sorry, forgive the interruption.
Right, now I've got a question now that coming on to that, Peter. So once a patient's tried the balance belt and they've been wearing it, is it something that they could then stop wearing? Do they get, or do you just have that on?
No, my experience is people just have to wear it the whole time. So it's basically replacing their balance system for them, because it's an alternative to vestibular implants, the surgical solution, which isn't yet available.
Yeah, the only reason I asked is we got a loan one, we were trying people with it, and then they could see if it was helping before they went down that route.
Yeah, so
I don't know if it was something that would ever come back into the system, I'm suggesting.
That's not been our experience. I mean, we've only been using it for a couple of years or so. And our experience is that probably need to wear it long term. And so what we're finding is that the company are really good. And they if one of my patients needs it, they send it over to me. And the patient doesn't have to pay anything for the postage or anything. And they send it over from Europe. They trial it for a month or two. We tend to get Michaela to assist the patient in developing, because you have to go through sort of a protocol of testing. You've got to make sure it's the right diagnosis. I mean, it's not something that everyone's saying, oh yeah, I'll give it a go, because that's a complete waste of time, and the company wouldn't be able to afford that, because they're a small. I have no financial links to the company whatsoever, but they're a really nice group of people, and they're really trying to help and be successful. And I think we need to identify the very small niche of patients who are going to benefit from this, and do it in a fairly structured scientific way, to make sure it's the right patient, and try and find of those patients who it's worth using, so they can purchase it if they want to. Yeah.
Thank you. And last question, Vimla, hopefully I'll reassure you now. Got your question squeezed in. In addition to her balance problem, she's recently been diagnosed with small vessel disease. Could this condition contribute or cause balance issues?
Oh, that's a really nice final question. Thank you for that. So the simple answer is yes. So one of my great heroes, who's Adolfo Bronstein, who's professor of neurology, he's just retired, in fact, at Imperial College, has done some very nice papers on this. And when cerebrovascular disease is when you sort of get stiffening of the blood vessels in the brain, we all have a little bit of it as we get older. And the more white spots you have on the brain scan, the greater the cerebrovascular disease. So it's usually graded mild, moderate, and severe. And Professor Bronstein has shown that the more white dots you have, the worse your balance is on average. Now, he's very keen to be clear, it doesn't mean the white dots are a cause of your balance problem. but we know there's an association between the worsening of cerebrovascular disease and balance. And if it's mild, it's probably not highly significant, and we don't do a whole bunch for that. If it's moderate or severe, there are two implications. The first is you need investigation. So you need to make sure your cholesterol is measured, your diabetes is measured, your blood pressure is measured, and you're not smoking. Those are the four sort of big risk factors for cerebrovascular disease. And to treat it, if you've got raised cholesterol, you can go on a statin. We'd strongly recommend that. If you've got raised blood pressure, you can go on blood pressure medicine. If you've got diabetes, you can go on diabetes medicine. So there are ways potentially of trying to stop it getting worse. And we treat it part and parcel with general balance therapy, with vestibular physiotherapy. So although vestibular physiotherapy is primarily designed for inner ear problems, it does help many central brain balance disorders, and it does reduce falls risk. So we still treat it, and we do seem to help still. So we think it's a really significant improvement in our knowledge and understanding of balance disorders. So that's a really good question. Thank you.
I was going to say thank you. I know you've already directly answered a few questions from the chat. I noticed them earlier, the ones that were done. So, given the time frame, Kevin,
I think we're done. I think we've reached the end. It's been a wonderful session, Professor Rea. A beautiful mix of questions dealing with
really interesting. Thank you.
So many issues. Thank you again, Professor, for everything you do. Supporting the group is wonderful, and I think today it just emphasises how complicated this crazy world is when you enter it with a balanced condition. That everyone else, all the general public, I'd never heard of Meniere's until I developed it, and I couldn't believe how a balanced condition could just cause so much devastation to one's life. And I think same with the general public. Nobody really gets it. Why should they? Until it affects them. But it's brilliant what you do. I say this every year that we really need to find a way to clone Professor Rea. So I think if we could get about 10 of him, we'd be onto a good thing. I don't know if your wife would agree, but we're not going to ask her. But thanks again for the time. And again, you're such a busy man, and to give all this time to us is wonderful. Likewise, Claire, you're a very, very busy lady in an audiology department in Royal Preston. Thanks so much for giving your time to us dizzy people. And just remains for me to say now the next meeting, just make a note of the date, Saturday, October the 17th. We will be sharing members' stories. So you will be contacted about this, and we are going to be looking for a variety of different conditions, members with different conditions. Your story doesn't have to be one of rags to riches, of how I'm completely cured. It's about the journey and sharing of that. I can assure you, everyone that's done it over the last 8 years in the group has thoroughly enjoyed it. And it helps so many people by sharing. So stand by for news on that. You'll get an email tomorrow giving you a link to the recording of this meeting, so you can listen to all of those wonderful answers from Professor Rea again tomorrow, and it'll be available to those who couldn't make it. There'll be further emails on we need your help to reach all the NHS departments, so we'll be asking you to send that in. And then finally, you'll have me pestering you to pester your MP, who is there to work for you. And don't take no for an answer until they've sent their questions to the Health Secretary, because that's what they're there for. But thanks, everyone. Remember, all of you members, you make this what it is, how good it is with your participation, contributions. We love what you do, Professor. It's honestly, we just need more of you. I hope you're training lots of people to come through, and we'll see you all in October. And thanks for a wonderful meeting. Thanks for everybody coming. You can come off mute now and give Professor Rea and Claire a round of applause for all the work they've done. So come off mute.
Thank
and make
you.
yourself heard.
Thank you.
Thank you for listening.
Thank you, everyone.
Thanks,
Enjoy your
everyone.
weekend.
Thank you.
Bye.
Thank you, and bye all. See
Bye.
you.
Bye.
See you
Bye.
very soon. Bye bye. Bye bye. Bye.
Bye.